Hi everyone, this is Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. We have here a patient who attended with a blocked right ear, and they've got really softened wax. They've been using some medical grade olive oil spray drops for a couple of weeks actually prior to attending, and it's not something that I normally advise my patients to use before attending an appointment, unless I'm treating a child. So with young children, just to because the oil can sometimes speed up the process. And if a child's got really hardened earwax and you're trying to remove it, it's a lot more difficult compared to most adults. Now, I mean, some children are brilliant, so it is the individual, but more often than not, children are less cooperative. So I just ask the parents to put some drops just for a few days or even a couple of days prior. And unless I've got a patient who suffers from keratosis obturans, where I get them to use actually sodium bicarbonate drops, which is more effective with a keratosis obturans than olive oil, I generally don't ask my patients to use drops. If I need to use it, I use it during the procedure. And the reason for that is if you use drops for a prolonged period of time, first of all, the manufacturers, most manufacturers of the drops, I think it's 5 to 7 days. But I know there was a pilot scheme recently, which if you've been watched my video yesterday, they were getting patients. So there's a community pilot scheme where pharmacies were performing earwax removal on the NHS, but it wasn't just pharmacists, it was pharmacist assistants who are non-regulated and non-professional clinical staff. And on that scheme, patients were advised to use drops for a fortnight, 10 to 14 days, which is a tremendous amount of time. And what can happen if you overuse drops? So it can cause the wax plug to absorb the drops and swell and expand. And in this case, it's actually made the wax too loose, too wet, too mushy, and it's difficult suctioning. So to counteract that, ironically, I put some fresh drops in. And with fresh olive oil, it almost like a coagulant, it helps to bind the wax together, and it's still, you can see it's blocking the tube. I have to give it a little shake and wriggle in there, and I'm just trying to peel it away from the top. So as we're getting a bit deeper, the wax is getting a bit darker, so it's a bit of an older wax, it's oxidized. I've got quite a narrow ear canal actually, and if memory serves me right, their cartilage portion, which makes up the outer third of the ear, it was a bit more firmer, it wasn't as flexible, and therefore it's more difficult stretching the ear open. And you'll see it once I remove this wax plug. Patient's ear canal, it's got a big crater at the base near the entrance. Now, it's not a canal cholesteatoma, it may be some benign osteonecrosis, but if it is, it's a very kind of early stage, very mild. What benign osteonecrosis is, it's when the floor of the ear canal, the osseous part, the bone, is lacking the vascular supply, so it hasn't got the blood supply that it requires, and therefore without the blood supply, the bone can't receive all the oxygen and the nutrients. You can probably see this pit now. I'm kind of looking downwards into this kind of crater, this widening, and in the absence of all the nutrients, oxygen, blood, the nerves that the bone needs to sustain life, the bone starts to kind of decay away, starts to die, and then the bone can separate, and basically it just creates a big pit at the floor of the ear canal, which wax can then fall into. So the wax, sort of laterally migrating out of the ear like a conveyor belt, it falls down this well and it gets blocked. And so the endoscope is actually tilted down probably about 45 degrees at the moment. So the eardrum is way up. It's actually off screen there, so let me just give you a perspective, and again you'll see it a bit more, it'll be more noticeable once I clear it. So going back to the olive oil, I was just trying to think of the word, and I think it's almost like an emulsifier. It helps to bind and homogenize the wax, to just make it a bit firmer. There is a layer of skin, you can see this dead skin that's enveloped around the plug of wax, and it's still attached to the canal, which can make it a bit more difficult to remove, because you're not only removing the wax, but simultaneously you're trying to detach the skin, the outer layer of skin of this wax plug that's still attached to the canal wall somewhat. So that type of skin, you wouldn't call it desquamous skin. So the skin that lines the surface of the ear canal is actually dead skin. They're called corneocyte cells, and they're full of keratin. They don't have a nucleus. There's no organelles there, so it's metabolically speaking, the skin cell is completely dead, but it's filled with keratin and acids called natural moisturizing factors, and these acids, they just draw enough moisture into the dead skin cell to keep it hydrated. Otherwise, obviously, our skin will be quite dry and cracked, but not excessive amounts, because ironically, these natural moisturizing factors, so uric acid, amino acids, carboxylic acids, they're also water soluble. So if they're submerged in too much water, they will kind of dissolve away, which can then cause adverse problems with the ear, because then the ear itself is completely void of any moisture, the skin cells, and the skin on the surface becomes very dry. So it's a fine balancing act. So I'll just put some more oil in there. Yeah, so desquamous skin is when this outer layer of dead skin, it's shed, so it's basically separated from the surface of the ear canal. And I think the term desquamous is Latin for the literal definition is descaling a fish, I think. Also, I've read somewhere. Where squamous skin is still dead skin, but it's still attached to the canal wall. And the term squamous means a flat kind of type of skin cell. You could, I think, again, the literal Latin definition is a fish scale. So the skin that was still attached to this canal wall, we couldn't call that desquamous skin. It hadn't shed. It was probably semi-desquamous. It was getting there. And it just needed a bit of a helping hand. Just a bit of soft wax in the inferior recess. Just peeling that away. There's a bit on the posterior canal wall near the cartilage. A bit of staining. Because I said the patient had been using quite a lot of drops. So we're just going to mop up now. Is this going to improve the patient's hearing? This probably would a little bit because the entrance is quite narrow. But I hope you can see this pit at the bottom. So now with a benign osteonecrosis, it's not common, like it doesn't always mean your ear is infected. You can get an infection, because what happens when you've got this pit, as I described earlier, earwax and dead skin, keratinous debris, would normally come out the ear. It'd be extracted naturally by the ear, but when you've got this pit, it falls down. And when it falls down, this pit, it can then lead to an infection. Some of the squamous skin that's still attached to the canal wall, it kind of crimples together, it forms a cyst. It can release some enzymes, some lysosomal proteolytic enzymes, which then start digesting away at the skin. It can ulcerate the skin. It can then lead to osteitis. Periosteum is a thin sheath that actually lines the bone. And it's the periosteum that provides the bone with all the blood and oxygen, nutrients that it needs to sustain life. And so when you've got periosteosis, the bone underneath, again, is starved of the blood. It's already starved anyway in a benign osteonecrosis. And then, obviously, when you've got an ulceration, it's not good. So there's no ulceration here. The skin's intact. With ear conditions, they can overlap, and you really need good diagnostic skills. You can get a canal cholesteatoma, for example, which can create a crater like this. But with a canal cholesteatoma, we know this is not a canal cholesteatoma, and the way we know that is that it's void of any otorrhea, because with a canal cholesteatoma, you will get some discharge, and you will have an ulceration. That's kind of at the first stage. You get some hyperplasmia of the skin, so build-up of dead skin, but this is more wax. It's a bit of skin here, but it wasn't a skin cyst. It was more of a wax plug that we removed. So that's one differential diagnosis between the two. With a keratosis obturans, the hallmark symptom of that is ear pain, and you'll get a global widening. But with keratosis obturans, it's actually desquamous skin. It's actually skin that's shed. It's almost shedding like layers of onions, and so the skin hasn't come outwards, it's kind of shed inwards. And with keratosis obturans, the desquamous skin, so the shed skin, so when the skin sheds, it should kind of flake away. So with squamous skin cells that are still attached to the canal wall, they are interlocked, So individual skin cells are connected together. But when they are shed, when they're desquamating, the individual skin cells should separate from one another. So it should be individual skin flakes. But with keratosis obturans, the desquamous skin is still, although it's come away from the canal wall, the layers of skin are still interconnected and in a lamellar structure. So the best way to describe that is if you think about medieval body armour, you've got the individual plates of armour that are connected. Imagine having layers of that. So with a lamellar structure, you've got thin sheets of skin that are interconnected, and then you have layers of them. And they literally just come away like an onion. But with that, you'll get a global widening. It wouldn't be localised. In that patient, you just saw it was the inferior canal wall, which is very typical of, that's the most common region of the ear canal, that where you develop your benign osteonecrosis. So, and then you've got malignant or necrotizing otitis externa, which can be very, very dangerous. And with that, you get the patient with reporting of a chronic ear infection. And with a malignant otitis externa, it's the temporal bone, so the bone that encapsulates the ear canal, that's infected. So it's a form of osteomyelitis, an infection of the bone. And then that infection of the bone can spread. And we're typically with malignant or necrotizing otitis externa, you get granulation tissue, which is inflammatory tissue. So connective tissue with its own blood supply, and it'll come from the floor of the ear canal. And the reason why it comes from the floor is obviously at the floor of the ear canal, you've got the temporal bone, and just where the cartilage meets the bone, so the osseo-cartilaginous portion, when the cartilage, there's gaps. We call that the fissures of Santorini. So underlying infections from the temporal bone, or also the parotid gland, so the largest, like the main salivary gland, the parotid gland, it's located kind of anteriorly to the front of the ear, but also inferiorly. So if that's infected, any pus, discharge, any neoplasms, like granulation tissue, it can actually travel up through these natural openings in the cartilage. And I say they're called the fissures of Santorini. And then obviously it can collect in the ear canal, and vice versa. You can get an infection of the ear canal, and if you've grazed your ear canal, the infection can travel down and seep out those gaps in the cartilage. And so, yeah, with a necrotizing otitis externa, because it's an infection of the temporal bone, and again, it normally happens inferiorly, then it spreads all the way around. You get build-up of granulation tissue, and with malignant or necrotizing otitis externa, it's a gram-negative bacteria, so they're very difficult to treat. They're very resilient and resistant to antibiotics, and the patients experience severe pain, typically at night, nocturnal pain, nocturnal otalgia, and again, patients who suffer from suffer from malignant or necrotizing, so it's given two terms, necrotizing and malignant. They are normally immunocompromised, diabetic or very elderly, and so that needs urgent treatment, that needs emergency referral to A&E or ENT. So again, the widening, there's a bit of a widening at the floor, so it's probably very early stages of the other condition, the one I described right at the beginning, benign osteonecrosis. That can also occur when patients who have undergone radiotherapy, because radiotherapy can damage the blood vessels. Okay, guys, well, that's my time up. I hope you enjoyed that video. Take care, keep well, and speak soon. Bye.